We have our guest speaker, Mirna Becevic, and she is going to do our presentation. But first, before I have her start, I want to tell you a little bit about her. Dr. Becevic's research is focused on telemedicine and telehealth and the role of virtual care in improving key patient outcomes. In particular, her research focuses on using telehealth technologies to improve access to care for rural and underserved patients. This includes early screening, timely diagnosis, appropriate use of the healthcare system, and distance continuing medical education. Mirna is the lead project evaluator for Show Me Echo for the Show Me Echo project, and I would like to turn it over to Mirna for her to begin. Thank you, Mirna.
Thank you so much, and thank you everybody for inviting me to speak to you all today about program evaluation. And I'm going to share my screen. Let me just do that real quick. You can see my screen, okay? Okay. So I don't have any conflicts to declare today. And today my talk is sort of organized in three separate sections that I think are interconnected. I do want to talk a little bit about the Show Me Echo evaluation team activities and tell you about the work that we do. I also want to describe and present best practices and some lessons learned from the Show Me Echo, and just ask some general questions maybe at the end to get us to think about maybe reframing echo research and evaluation approaches and some different ways we can actually do that. So one of the first things that we did as a team, as a Show Me Echo evaluation team, we realized that, when we collect the data, report that data, that we don't necessarily all on the same page when we say, for example, attendee or a learner or a session, unique. And so we kind of realized that one of the things that we needed to do early on was to harmonize and standardize this terminology. And this took us a little bit. We, searched the literature, we read a lot, talked to our colleagues, and we put together all of the jargon that we typically use in ECHO and defined. And so this is a lengthy list, but I wanted to show you what this looks like. We do include this in all of our annual reports. So when you read the report and, we use a term such as, session attendance, you can see what that means. We define primary care provider. There are different definitions, for example, of primary care provider in the literature. And this is the one that we decided suits our Show Me Echo best. And this is the one that we decided as a team moving forward, we will use it in all our reports and also publications. So this has helped us tremendously. And this is also helpful when we receive, any requests to provide any ad hoc reports, or, if anybody is doing maybe a manuscript on an ECHO topic and they need some data. If they don't define this to us, we will make sure that we're all on the same page. So if they request, we need to know the total attendance. That means including hub team members or not including hub team members. If we say others, who does that include? Those that are maybe registered to attend sessions, or maybe everybody, including students. So, this has helped us tremendously. So I just wanted to bring that up as well. Some of the things that our team does on a pretty regular basis is routine data collection and reporting, ad hoc reports, and also help with research and publications as well. And so I listed some of these activities, and I don't have to read them in particular. I think you can all read them and see them, but I just wanted to say that we have certain surveys that are scheduled to go out on a regular basis, and that's what our team manages. And those surveys have already agreed upon questions. However, every once in a while, either a hub team or a member of the hub team will want to have or get some additional information that may have to do with, say, quality improvement or getting some particular information from the attendees or the learners. And so we will either include some additional questions during our regularly scheduled survey collection times. But if they want us to create a new survey or do some new interviews, we ask for at least 10 days lead time to do so, but our team will typically lead these efforts. We also help with research if there is a particular research question that somebody has. Now, not most of the time, but some of the time, I guess, these research activities are grant funded, and we will either be members of those research teams or provide information to them as needed. But our team will make sure that there is an appropriate IRB approval before we provide any kind of data that's used for research. Information that is collected and analyzed is typically provided to the Show Me Echo leadership team. But I also wanted to talk a little bit about information that we provide to hub teams. Session recap is typically done by Echo coordinator, but they can do this also working closely with evaluation team. And so what they do is after each session, they will sort of provide a session recap with the list of attendees, didactic topic presentation, and also any case presentations that were discussed during that Echo session, and any comments and suggestions they might have. Show Me Echo evaluation team also provides an annual report. This is typically published in January for the previous year. And the data that's presented in the report is used to demonstrate the impact of the Show Me Echo program on Missourians. And we use anything from attendance data to self-efficacy surveys, sometimes even into case studies or publications. We also provide individual echo reports to each individual echo. These are done semi-annually by the evaluation team, and information that's provided to hub teams includes attendance. We map attendees so they can actually visualize the reach of their echo on the state of Missouri. We show any trends in self-efficacy and also any suggested topics by the attendees. And these are actually used then by hub teams to create curriculum for the next year. So, when we started evaluating echo, we kind of sat around the table and started talking about the best way to approach echo evaluation. And as you can see, these are some of the words, that have to do with the type of program echo is, the methodology that is used to evaluate a telehealth program or continuing education program or virtual education program, ways you can apply that methodology. And so it's really messy. All of this was sort of all over the place. And there's so many different ways to actually and evaluate a program, a complex program like ECHO. And so after we've done this, it became very clear that we needed a framework. That would help us organize all of these thoughts, all of these different methodologies and approaches and different types of data that we actually collect through ECHO. So we as a team adopted Kirkpatrick model. A lot of other ECHO programs or even telehealth programs use Moore's model. And these are very similar. Both have a number of benefits and some challenges as well, but they're very similar. So, if you do a Let's search or read any articles on ECHO or telemedicine evaluation, you may see either one of these frameworks. And I'm just going to talk about this one because I'm familiar with it. And this is the one that we adopted early on. And so when you look at this Moore's pyramid, to me, it reminds me of the research pyramid, if you're familiar with that. And so on the bottom is sort of your lowest level of evidence, which is still very useful and extremely important, but it tends to be highly subjective. And so, and I'll talk about each one of these separately, but I do want to kind of point that out, that on the bottom is your low hanging fruit. This is the data that's the easiest to collect, maybe highly subjective, but it will also give you a lot of information on, how your program is doing, and if there is anything that you need to improve. And as you move through these different levels and get to the top of the pyramid where, we have results, this is your impact on the community. And this is typically data that's harder to access and harder to analyze, but it's the most complex type of evaluation and the hardest evidence that you have regarding your program. And so these are the levels of the Kirkpatrick pyramid and the type of data that we collect in each level. And I'll also show some examples with the actual data that we have. So I think that helps kind of give you an idea. So the first level that we saw was a reaction. So this is your aggregate attendee data. Who is coming to your echoes? How often do they come? Do they come back? What types of providers or participants do you have? Any satisfaction surveys, and then CME and CNE, any continuing education surveys as well. The next level is learning. So this is our self-efficacy surveys. And we have also done tacit knowledge surveys in some echoes as well, pre and post echo attendance. The next level is behavior. This is where we're looking at behavior change. We have done this through temporal case analysis. We have done this through adoption of melanoma high-risk surveys. Now, I want to be transparent and say some of these in level 3 we have done through some outside funding, grant funding, just because we needed additional support and we were lucky enough to get some funding. But it's also kind of falls into this Kirkpatrick pyramid of evaluation as well as research, if that makes sense. And finally, on the top of that pyramid is the impact on organization, population, and your community. And we do this through analysis of Medicaid claims data. And I have a couple of examples of that, and also chart review. And I have that in brackets because we haven't done it yet, but we're in the process of requesting some charts for review in several different clinical echoes. And so this would be the example of how we report that first level of reaction. So the map, I don't have a legend over there, but this is a map of, all of the echo participation. I think this is from last year. So we even have more today than we did last year, but I just use this in my slides because I think it looks wonderful. And it really does show that we, we have participants from each county in Missouri. So this is our participation map, and we can show it in many different ways. Each echo will receive their own map. We can show repeat participants as well as those that come just once, maybe never again. We also have information on people that register but don't come back. And, a lot of information we can learn a lot from just studying and analyzing attendance. And so this is in our reaction. And also we ask some satisfaction questions in our surveys, and you can see examples here. What aspects of echo are most helpful? How would you rate following aspects of echo? And typically we ask questions about the session itself, the value of the presentation, actual clinical topic, as well as the administrative support. So in the next level, I mentioned self-efficacy surveys, and this is an example of autism self-efficacy survey. We really try very hard to use same questions in all clinical echoes. So this allows us then not only to evaluate each echo separately, but also make comparisons between different echoes. So you can just see the questions on the bottom, and what we typically do is keep the question the same and just replace the condition or a disease. And then we can compare them across different echoes. And we can also do trends as well and look over the years if self-efficacy has changed or is changing as we move forward. So this is what I mentioned earlier that we did with the support of a grant, but we wanted to see the provider behavior change. So one of the things that we did is we have dermatology echo that at that time was a weekly echo every Friday. And we integrated melanoma echo once a month for 11 months, and we provided melanoma related topics. And one of the things that we did is also provided high-risk surveys to participating PCPs, and we asked them to give those surveys to patients that come to their clinics for, their regular patients that were not coming necessarily for a skin check. But we asked them to, survey their patients, and if they identify their patients as high risk for melanoma, we asked them to offer a skin check, and the nurse would put them in a gown, and that would be a cue for a clinician when they came into the room, if the patient was in a gown, that they also needed a skin check during that visit. And during our very first melanoma echo, we had a dermatologist that demonstrated and provided information to PCPs on how to effectively integrate skin checks into busy PCP clinics. And, after our study, we did realize that, this was this kind of support was helping PCPs change behavior and successfully integrate these skin screenings in their clinics. And they found, as a matter of fact, only 10 providers found, as you can see, almost 1,000 high-risk patients and identified 36 new melanomas on patients that were not actually in clinics for a skin check. So, Echo platform really was a great way for them to come and ask any questions, bring photos, show photos, and get support from a hub team of dermatologists. And finally, I do want to give some examples of Medicaid claims and how we analyze Medicaid claims. And we've done this in several different echoes. And my example that I'm bringing today is on dermatology. So what we did is we analyzed participating provider claims count containing one or more specific dermatology diagnosis codes. And so our medical director is a dermatologist, and she provided top 10 most common dermatologic diagnoses. And she also provided 10 very rare but important to know diagnoses. And we pulled claims data. And so this data was unique and individualized for participants based on their echo participation. So each participant, we received information for 12 months before they started attending echo and 12 months after attending echo. And so what we found is that before echo, they only made 101 of those diagnoses. Some diagnoses were not actually made at all. And this number went to 382 diagnoses, which is increasing 278%. But what's really interesting is that this number actually includes, even though those participants that attended just one echo and never came back. And so when we actually focused on those that attended more than one echo, 2 or more, this number went to an increase of 452% in making those diagnoses. And so I want to go back to this slide just for a little bit and say, using the Kirkpatrick model, organizing our data collection and analysis in an organized and meaningful way, sort of help us be able to really focus on all of these aspects of echo, but in a way that kind of guides us through evaluation from the lowest level of evidence to the most complex. And now we can sort of, see we still have everything, we have different approach. Not every approach works for every echo. So for example, what I mean by this, there's certain echo where, chart review is definitely appropriate, but this is not appropriate for everything. We have quantitative analysis and qualitative analysis that we do just based on different echoes as well. Now, I do have randomized control trials on this slide, and I do want to bring this up because this is sort of a gold standard of research, not necessarily evaluation, but we are working very hard on trying to make this happen and get this approach in at least one of our echoes and have really a group of echo participants and non-echo participants and study the effect of echo on provider learning, on self-efficacy, but also on patient outcomes as well. And so here are just a few things to consider when you are starting to design your own evaluation approach. We work very closely with, we as a Show Me Echo evaluation team, we work very closely with the leadership. Our evaluation approach is based on strategic planning, and we do match our approach and data collection to individual goals of each echo as well. Want to change with echo? What is your echo or even your telemedicine program? What are they? What is the ultimate goal? And just make sure that then your evaluation matches those goals. How are you framing the change you want to observe? What are the key considerations when designing your research and evaluation for this particular outcome? And what are the benefits and limitations of the framework that you're using with the model of the approach? And like I said, we adopted Kirkpatrick model and it works very well for us. We feel like this has really helped us organize our data collection and reporting as well. But I am sure that there are other frameworks that would work just as well. And so these are just some takeaways from our program. Echo is definitely a complex phenomena, and some will view it as continuing education program, but it's also access and equity. There's so many different ways to look at it. It is also important to automate data collection processes early if this is possible for your program. Combining different data sets is also very helpful, so you don't have to do this manually. And we learned this the hard way. We collected data. Some data was in REDCap, some was in PDF forms, and it was scanned. And it took us a little bit to combine all these different data sets. And let's not forget, we record echo sessions, which are also full of very important and valuable information. And we have analyzed video recordings and pulled the information from video recordings as well. So anything you can automate early on is always very helpful. And I already said this, there are benefits and limitations really to any framework. So just my advice is just to find the framework that works for you, but it's important to have one for sure to help you organize your data and how to help you also figure out how you're going to report that data as well. And consider how the outcomes you want to measure fits, the approach and the knowledge translation and education as well. And so I provided some references that I used in this slide and also some references that we use frequently. So I'm just going to leave this here for a minute and open up for any questions you guys might have or any comments.
How did you create, or how did Kirkpatrick create the tier and the value, the evaluation for the tier from results to reactions? Because that's kind of curatorial.
So Kirkpatrick model has been used in evaluating, it was created to evaluate educational programs first, and then it was adopted by medical schools to evaluate medical education. And so, that pyramid, is Kirkpatrick pyramid. There's actually some of them that have 4 levels, some that have 5 levels. And, we adopted one with 4 levels, but we read a lot of literature on this. Let me tell you that first. We read a lot of literature that sort of help us. So we learned from how they evaluated education and medical education in particular, and adopted a lot of that approach. And so we actually, how we did that was, by writing down all of the different data sets that we had at the time. So we just wrote down, it was a humongous list of, anything and everything from attendance to registration to recordings to, we did some interviews. So we wrote everything down and then looked through that framework and tried to see where that fit. And so it just kind of made sense that, aggregate data and attendance is the basic reaction. And so we went up the pyramid and came to chart reviews and Medicaid claims data as the top, where the influence of the program on the community would be and the population would be. Because through claims data, for example, or chart review, we really can look at everybody. So if a clinician attends ECHO, for example, we can look at their entire panel that they treat of patients, with that. So if we have somebody attending, let's say, asthma, and oh, Karen, I see that you have a hand up, but let me just finish my thoughts. So in asthma, for example, we can look at their entire panel of patients with asthma and look how they're utilizing healthcare system. Are they using outpatient visits more? Are they using inpatient? Are they being hospitalized? Are they in ER? So we can see how maybe that is affecting their attendance in ECHO is affecting all of their patients. Karen, did you have something to add?
I was just going to invite you, since this is the telemedicine echo, to think about how this evaluation could be adopted to a telemedicine program. Like, Mirna, how would you, not to put you on the spot, but like, how would you think about, like, if you just had a telemedicine program, how would you think about evaluation?
So one-on-one telemedicine program. So I think that, again, I would go back to a framework that could help you, what is the objective of your telemedicine program? So is it to increase access to your patients? Is it to improve access to your patients? Is it to provide access to different types of specialties you might not have? So I would really also look at, Kirkpatrick model, even though it evaluates evaluation, something similar could be adopted to a telemedicine program, where, if you currently have a telemedicine program, surveying your patients on satisfaction would be really, really important. I would also include clinicians in that. Are your clinicians satisfied with the program? Are they satisfied with how everything is set up? Are they happy with it? Are they confident in their ability to see and treat patients that would be a next level of that's more complex, and here you can also ask them questions about seeing patients in person and seeing patients via telehealth. Do they see a difference? Are they more confident doing one or the other? Model like this could definitely be applied. And as you move up the pyramid, that would help you what data you can collect. You could also do a chart review. You could do a chart review of your telemedicine patients versus non-telemedicine patients and look at any differences you might have. One of the things that I think with the telemedicine program that I see in literature that's really important is looking at the no-show rates or cancellation rates with telemedicine versus and if there is any kind of difference, in the negative, let's say that, maybe your telemedicine patients are canceling more or no showing more than they do in person. What is the reason behind that? There's a lot of quality improvement that could be done, if you do notice something like that you could definitely find from your evaluation program. So what is it that's making it? Maybe it's the technology, maybe your patients are not comfortable or it's not working well. But that's definitely something that you can ask. Does that answer your question? Is that helpful?
Yeah. You want to stop sharing so we can all talk to each other?
Oh, absolutely. Yeah, absolutely.
I just was wondering why the tier at the top was the results from, I guess, insurance and prescribing and that kind of as a result of to measure. And possibly thinking about maybe not looking at it, putting other things in the place of one, two, three, four, like an outcome for the ECHO participants. Their I'm at a loss for words, like
their health outcomes.
How the people who are coming to ECHO utilize the information, synergize or integrate into their own practice might be a better measure of ECHO than those other things in the 4 or 5 tier for us to see how we can improve or measure our success, or what could possibly be things to improve echo.
Rachel has a
And
hand.
I appreciate the answer.
Sherry, I'm going to try to just give an example of the way that we talk about it within our groups. Sometimes we talk about our echo is going to be successful if we see behavior changes in healthcare providers, if we teach them something new. So if we teach them how to diagnose melanomas, we want to see a behavior change whereby their clinic staff identifies high-risk patients. They do a melanoma skin exam that they didn't do before. So a behavior change in the healthcare provider is one thing. Sometimes we also need to see a behavior change in the patient to see that that healthcare provider was providing a different level of care. So when we were evaluating our asthma echo, we looked at before echo and after echo, how many times kids with asthma were visiting the emergency department and how many hospital days they had. So when we saw a decline in both of those measures, a decline in emergency room visits and a decline in hospital patient days for patients who were cared for by people who had attended the asthma echo, that could lead us to believe that that echo in part was doing some good work to change the behavior of both the healthcare provider and the patient. Does that make sense?
It does, but there are other things that might, skew that, only because we've had COVID, so a lot of patients weren't seen, so that could make it look like they had less use, less
Correct.
interaction, but
Correct.
not to be conflicting, but maybe their water intake, or they're exercising more, or they're doing things to be more preventive that you might not get to see, like, before we go out and play outdoors, I'm going to hydrate, different things that impact, or I'm going to my appointments more frequent, other things that impact, or I went to the nutritionist. Like, there are things that,
Right.
what about resources for camp,
yeah,
the asthma camps that educate
that's
kids.
right. We agree. I mean, we can't be completely
do everything.
comprehensive, but we did look at how often they were going to their outpatient provider, and that did go up. So we measured that too. And then we also measured the use of the inhaled daily corticosteroids, because you can measure that when you look at the claims data for refills.
Mhm.
So yeah, I think if you have ideas on how we can additionally look at any of our programs, we would love for you to share them with us, because we're creative people, but we can't think of everything.
Right. Well, I appreciate that. And again, like I said, I think that lower tier probably has more things to flush out with regards to the wellness and preventative side that might not get caught in that medical treatment data, just to make us, more accessible to other funding and more expansive. Because I think you all are professional doctors, but as community health workers and wraparound services like home evaluation for mold and that trigger asthmas, like carpets versus hardwood floors, things that people don't think about, like cleaning materials. Oh, I stopped using Clorox and ammonia. Thank you. But some people think, a lot of irritants. Oh, I only clean when the kids are outside, or, I lift the windows up every day to circulate it. And that's just a minimal focus, but that kind of information helps the patient and family be proactive, because everybody thinks, oh, the inhaler, but we know those steroids over a long period of time, or albuterol and different things, are not, they're just helping with relief of the symptom, but not really addressing the issues. So that's an idea to think about, another section in there. But anyway,
That's
thank
really
you.
important feedback. Thank you for bringing that up, because it does make me think, we're starting smoking cessation echo, and I've heard a lot of discussion. I wasn't a part of this group, but I have colleagues that are on the hub, and I've talked to them. And I think what you're bringing up is so important. And I'm glad that you did, because I will share with them. There's a lot of talks between the hub team members on what they can utilize, what kind of resources, and what is important to educate other providers and community healthcare workers and anybody working with patients on changing that behavior. And so, what you're talking about with asthma is very similar to smoking cessation. So I'm just drawing that line, and I really appreciate you bringing it up. So thank you.
And thanks for receiving it. I appreciate that as well. And I really appreciate this group because it brings information to me. And sometimes because I'm, in that group on the one, I just feel like, where can I find information to support what I do, which is non-medical, but can be impactful because that's that wraparound service piece. And that's a big new piece in Medicare, medical care that hasn't been addressed before. So I'd like to make sure that information's in there so that we can show the measure of how ECHO works with integration and community health workers, just for the long support, because funding is tricky. But anyway, thank you this morning.
You're welcome. Thank you.
Does anyone have thoughts on evaluation of ECHO programs or evaluation of telemedicine programs, especially if you're thinking about writing for a grant and you're going to be looking at the how you're going to evaluate your own program?
I would just say that, there were many of us doing telemedicine long before the pandemic for decades. And I think the satisfaction surveys are great, but there's been so much literature on satisfaction in telemedicine. So don't think that that's something new that you're going to get published on because if you look at the American Telemedicine Association and you look at all the special interest groups and you look at all the literature, there's just a boatload of satisfaction data on telemedicine. And patients are satisfied and providers are satisfied when it works well and they have operational support and the technology works well. Also, mental health patients, mental and behavioral health patients are particularly satisfied with telemedicine, as it turns out. In the very early days, we worried about that. We worried honestly about like schizophrenic patients and then the TV talking to them. And so we really did worry about that in the telehealth world. But it turns out that psychiatric and mental health and behavioral health patients really like getting their care through technology rather than going to the office, being seen going to the office, sitting in a waiting room with a bunch of other people. There's satisfaction is kind of, in my view, satisfaction has been done and settled. Please disagree with me if you want to. I mean, you might want to do satisfaction in your own clinic to make sure that everything's working well.
It looks like Evelyn has a comment on that, Karen, in the chat. She says one thing they often hear that if an organization has satisfaction and engagement measures in on-site clinics, think about utilizing the same measures as part of quality improvement in the telehealth setting. So always thinking about improving the processes, whether you're looking at an echo or telemedicine or whatever your project might be. Anybody else have experiences they would like to share? Robert, you unmuted for a second.
Well, I was just going to say one thing that I often find, and I actually have some arguments with some of our federal grants on this one, is that one of the things that could be most interesting about your telehealth program versus your in-person clinic program is kind of what each is being used for, and looking at which age groups accept, what types of diagnoses seem to work better. Because I'm always a big fan of, right, I used to be a CEO, got to figure out how to make it cost effective. So it can help you understand where telehealth, just like Karen was saying, right? Behavioral health, psychiatry, those are well embraced. There are some other areas, but it can tell you what's working well or where your patients are going to be quick to uptake. And those may be places to start with telehealth. The other place is stuff you don't have available in your local community. I always push for. So, and don't be afraid to ask your patients what they would welcome and how they would welcome. We're often not as innovative as our patients, and our patients can tell us what would make their life easier and more practical and more possible. I mean, I speak as someone who went to telehealth for behavioral during COVID and will never go back. I mean, it's so dumb for me to leave work, drive in my car, sit in an office. I waste so much time when I'm talking to a person face to face, and we're all used to that, or a lot of us are used to that now. The other thing that has really come out, looking at the data about the quick turn to telehealth, who got left out? And think about that with your patients, right? Rural populations, this whole audio only issue, older populations, because that's the other thing to think about. Not only your patient mix, but if you really want to make your telehealth program successful, those groups that find it difficult to adopt, lack of broadband access, lots of other things, just unfamiliarity with software and IT, really think about what's going to make it possible and doable. And out in Western Kansas, Dr. Evelyn was involved with a federally funded project that they took the iPad to the house during COVID with a person there to work the iPad. Anyway, these are all the things I've seen and think about, because I'm a little bit tired after 20 years of this, of hearing we tried telehealth and it didn't work. And they had a cart sitting in a room. Get rid of the carts, first of all. They don't work. Anything bulky, anything that takes an exam room that you need for other patients, when you can have somebody doing telehealth in an office. Anyway, I'm sorry, I go on and on and on, but all of these are evaluation metrics. And often we don't have successful programs because we're not spending enough time understanding how to make them successful.
And I would add to my comments about mental and behavioral health, other patient groups that telehealth is particularly good for. In addition to who you think in rural and frontier areas, if they have the bandwidth to do it, also frail elderly, patients who find mobility very difficult have embraced telehealth in a big way, and parents of small children. So if you think about it, it's very difficult. Many young families have multiple kids, and there's a high no-show rate in our clinics because it's difficult to wrangle everybody to go or to get childcare. And so we found, when we instituted at the University of Missouri the patient portal, at least in my department in dermatology, the biggest users were parents of small children. And sometimes, not too far from the medical center, but both for themselves and their routine health needs and the needs of their children. So I just wanted to add that.
I would say that it's very beneficial, telehealth, but I would also say that the bandwidth of people has not been explored, like really who's teaching them how to use the portal and telehealth, and making sure they can have access. And that takes more than a nurse or MA teaching them or setting them up. So even maybe that's something to look at, supporting them in accessing the benefits of telehealth.
There's no.
Molly, you have a
Oh,
question?
I was just going to comment in relating to evaluating your telemedicine or telehealth program, and kind of going back to what you said, Sherry, about level 1 reactions, and then all of the comments related to the clinical use of it and the satisfaction. As a program, you can always take your satisfaction, your patient satisfaction related to telehealth, whether it's 2 questions or 10 questions you're asking patients. You can tie it back to what was mentioned earlier with no-show rates, or those not being able to get connected. And then you can go back to your workflow. As simple as your workflow is, or as complicated as your workflow is, go back to the echo that we had covering that piece, and you can look at where those gaps are. And so if you're tying together, okay, my patient wasn't able to connect, we only had 5 minutes on, or whatever it was at the end user, you can tie it back to, and always look at your workflow and see if there's pieces that can change, whether it's your entire clinic, it's a hybrid program, or it's a complete telehealth follow-up program that you're using. You can use this data that you decide is valuable to your program and tie it back and make those changes within your clinic and your practice, or your, even if it's a health education program, maybe it's not a clinic-based program, but you're offering a telehealth, maybe it's smoking cessation or something like that. So there's ways that you can use evaluation and a little quality improvement, kind of tie it together and make it fit what you need within your clinic.
With our clinic, we have, I won't say resistance, but anything new in dealing with the computer, with some of our senior providers, it's, I've been told in OB, we don't need that. There's no reason for us to use telehealth because we have to see the patients. And I was like, well, not necessarily. Like birth control, follow up with STD treatments, like that all looks like a good telehealth. And so I was like, well, no, you can't give an exam through telehealth, but there are so many things you could do with it if you just try to use it, So anyway, any suggestions of how to get people to use telehealth?
There's a good study, and I'll find it, and Beth can share the link with you all if you all are interested. But this doesn't have to do with, this is not evaluation, but it's more from operations and kind of managing administrative side. But it's a great study that was done a while back, and I think it's the reason why we have vans for mammograms these days. But they actually studied women who were at high risk for breast cancer, and they provided free screenings and access to free screenings. And they wanted to measure how far those women would travel for free care. And 20 miles was what they found. If the visit was within 20 miles, that wasn't considered a burden. Everything beyond 20 miles was. And so when you think about your telehealth program, just kind of, is there a way you can pull reports? Is there a way you can look at where your patients are actually coming, how far they're traveling to see you, and maybe offer telemedicine to those, because there is evidence that they will cancel those visits if they're more than 20 miles away from your clinic. And so I'll share the link with Beth, and you can read the study.
Because we have a huge DINCA rate, like where we could put 3 in the appointment and none of them show. So we're overbooking our providers because our DINKA rates are so high. And it's based on transportation oftentimes. The same thing you said about wrangling kids to get on the bus, or transportation, not having car seats for everyone. So the insurance provider will not allow them to ride because of, safety issues and insurance issues, and or rain or snow, or all the things that affect families. And sometimes they're just wellness checks that, a check-in, and just really, you know, you know.
Any other questions, concerns, comments? Okay. This is the last telemedicine echo for this session. The hub team is going to be meeting in August to plan the next curriculum. And so we should be back live, I would say, after Labor Day. Okay,
Can you hear me?
I can. Yes, Heidi,
Okay.
please go ahead.
So I did leave a comment. I guess nobody addressed it. So I am a little bit, I've listened, I've been here for every session for the last year. Most of the time I've been in my car. There have only been about 2 sessions I've actually been physically in a building, because I'm always on the road. I'm about as rural as anybody here can be. I work in a very rural community and I travel constantly. I do house calls. I work in facilities. I see my hospice patients in their home. I go 2 hours to some of my furthest communities. I could benefit from this probably most of anybody here. But when the fellow commented on how he's tired of listening to people complain about how they can't get their program started, that really insulted me. Maybe people can't get programs started because they're really difficult to start. I don't feel any closer to starting my program at the end of this than I did at the beginning. And that really bothers me, because I'd really thought after 12 months of listening to your program that I would be in a place to start a program, and I don't. I don't feel like I learned anything about what kind of equipment that I could get. Nobody has reached out to me individually. I've been sent emails, but nobody has personally reached out and said, okay, let's set up a time. I've been sent emails and told, okay, you can call us, but nobody's called me. I've not gotten any sort of structured, as a physician, information about how can I literally get this thing going. I work in a community by myself. I have nobody else to help me with a program. And I'm no closer to starting one now than I was 12 months ago. I have no internet. I put a comment out there, when I go to my patients' homes, I've got no way to get reception. I can't even open my own phone and enter my own data into my own EHR on my phone, because there's no reception. And so I can't expect them to be able to communicate with me via telehealth from their home. And the response I got when I said, what do we do with that, is somebody said, well, use telephone. So how do I start up a telehealth program when my patients can't do that?
Heidi, this is Rachel from Missouri. I really appreciate you being honest and talking to us about what you haven't gotten from this program. And what I will say to that is that this program is designed to help people understand the basics. And I believe you're in Oklahoma, isn't that right?
Yes.
Yeah. Okay. And so, and I apologize for nobody reaching out to you directly and setting up those meetings to further help you. And we can definitely do that. And I will immediately following this session, I will reach out to you directly and get a series of meetings set up so that we can one-on-one go through some of the different steps that may be able to help you. So, one of the things we don't have is funding to be able to help you, but we do have information that can help you. So I apologize on behalf of the Hub team and the ECHO program if you felt like that this has been not 100% what you thought it might be. I do appreciate the feedback though, and I will get back to you.
Thank you.
We do have a couple minutes left if anyone else has anything that they would like to share with the group before we go sort of on summer break.
Just keep in mind that there's gazillions of dollars coming into our states to increase broadband right now. And so that's one of the things, that we all need to keep in mind if we have a place that really needs it.
I would also suggest to Heidi that your patients that you're seeing, their insurance providers do have things that would support them that are non-medical, such as broadband for people who are disabled or have Medicaid or Medicare. And that's not a physician's responsibility or provider's responsibility, but those resources are there from the insurance companies to provide them with smartphones.
It just doesn't exist though. It's not that they don't have them. The service doesn't exist.
Oh, there's no internet in their area. I apologize. I didn't understand that part. Well, that's huge. Maybe the
Yes.
city council or city official or county
It's everywhere around here.
Yeah, would consider that. I don't.
It's everywhere around here.
Yeah. That's a special circumstance. Yeah.
Thank you, everyone. It's been a pleasure seeing you. And Heidi, expect to hear from me momentarily. And everyone else, have a great summer, and we will see you this fall.